and you don't know how to land, it will be dangerous for yourself and the passengers boarding on that flight. So my presentation will be based on the principle of KISS. KISS is a very lovely word. So I will request my all residents to just please smile, be relaxed, and I will try to make this presentation KISS like keep it simple and stupid like me. Just I will move on. So when there is a need of mechanical ventilation, it is required when other modes of oxygen therapy fail. Other modes of oxygen therapy has been well discussed by Dr. Mohit Bansal in a nice way. So if those modalities fail, then there is need of mechanical ventilation. Other modes may fail due to late start of these modes of oxygen delivery, due to inappropriate operation of other modes of oxygen therapy, due to no response to the medication used to treat the disease responsible for that, and sometimes, my dear learned friends, there is catastrophic presentation of disease giving no time for other modes of oxygen therapy, and directly when the patient comes to you, you will have to put the child on ventilator. And I have faced one such condition in a simple disease like asthma. The patient came, it was sitting in OPD and landed in problem and directly put on ventilator. So, my dear residents, just as a batsman keep his eyes on the ball but continuously read the mind of bowler and vice versa, just I request you to please keep your eyes on my slides but continuously read my face and read my mind, what I am going to tell, what I am going to describe. It is not possible to put all the things on the slides because it will be very lengthy and it will be boring. So, in terms of indication, the first and foremost indication of mechanical ventilation is respiratory failure. I will describe what is respiratory failure. Second indication is to prevent the exhaustion of overworking respiratory muscles. So sometimes there is need of respiratory muscles to overwork for compensation, and there is need to increase the rate and increase the depth of respiration. And if we live in that condition, there will be exhaustion of the muscles, and muscles will fail and paralyze. We cannot do anything. Next indication is to protect the airways in unconscious patient and patient with neuromuscular disorders. In these type of patients, there is no problem in the lungs. Lung is perfectly normal, but problem is in the consciousness of brain, and that patient will not be able to handle the airways. There will be secretions pulling in the airways, and there will be problem for that. So the next indication is to support left ventricular performance in cardiogenic shock resulting from the left ventricular dysfunction. So in this condition, we will also require mechanical ventilation. And lastly, to treat intracranial hypertension, I will not touch upon this topic. So I will start from respiratory failure, which is the foremost and most important cause or indication of mechanical ventilation. So there are various reasons of respiratory failure. My dear learner friends, just I will start from top to bottom, right from the higher center to the lungs. So where can be problem? Just assume where the problem can be leading to respiratory failure. So there may be less or no drive from the respiratory center in the brain due to some lesion at the respiratory. The signal comes from that place to the entire horn cells, and it will then deliver. So if there will be problem in entire horn cells, there will be no breathing, respiratory failure. If horn cell is also normal, there may be lesion in the efferent nerve going to the respiratory muscles. If there is problem in the these nerves, signal will not travel. Then if it is also normal, there may be problem in neuromuscular junction, and the signal will not cross this junction. And if this junction is also perfectly normal, there may be problem in the respiratory muscles. There be myopathy and muscle is not working, so there may be respiratory failure. And if this is also normal, there may be problem in the airways. So if there is no way for air to pass, how can air pass and go to the lungs? So there may be problem in the airway in the form of various types of obstruction. I will not go into detail. And if these all are perfectly normal, there may be perfusion at alveolo-capillary membrane. This is important. I will describe. And lastly, if all these things are normal, right from brain to enter horn cells to efferent nerves to neuromuscular junction to muscles, airways, everything is normal, there may be defect in the ventilation perfusion mismatch. And what is this? I will describe in some detail because this is very important. So respiratory failure may be of two types, hypoxemic and hypercapnic. There are different terms used in many books, type 1, type 2. Forget about this, but just remember, may be of hypoxemic or hypercapnic. These may be acute or chronic. So there is no absolute criteria on which ventilation should start, but reasonably it has been agreed upon that mechanical ventilation should be started when the level of oxygen in arterial blood is less than 60 millimeter of mercury while breathing more than 60% oxygen. There are so many devices other than ventilator which delivers oxygen at the rate of 60% or more, which has been discussed already. Or if there is PCO2 more than 60 millimeter of mercury or pH is less than 7.25, these are the indicators of derangements of gas exchange. If these are there, we need to put the child on ventilator. Now, what is hypoxemia? My dear learned friends, alveolar gas equation, why I have put it? We are seeing this alveolar gas equation right from our physiology class and in the book of Ganong during our MBBS. But it is very difficult to memorize anything which is written in the formula form ABCD F1 minus 2 1 minus 2. That's why I have modified to make it simplified. Just forget those formulas, just remember the concept, it will be clear. So I want to know what is the alveolar gas, what is the concentration of oxygen in the alveoli, how it will be decided. See,
slide show kar lo.
Slides.
Slide show नीचे जाइए, नीचे slide show कीजिए.
Slide is not visible.
नहीं, slide is visible. Slide show कर दीजिए.
Slide show. Okay, thank you, sir. Thank you, sir. Thank you, sir. Yes. Okay, now, so this I have made, now it is clear, sir?
Yeah, yes, thank you.
Okay, thank you, sir. So, alveolar gas equation, I have made it simple. Just see the concept. What is the concept? Concentration of oxygen in the alveoli and blood depends on two things. What concentration of oxygen is going inside and at what pressure it is going inside. So the inspiratory pressure is decided by the atmospheric pressure where we are standing. Roughly at the sea level, atmospheric pressure is 760 millimeter of mercury, but here it may be different. And in some ventilators, the newer ventilators, where we will keep the ventilator, it will display the pressure, atmospheric pressure of that room or that place. Okay, so this is the atmospheric pressure, and when the gas passes through the airway, it gets saturated with the vapor pressure in the airway. So this pressure, atmospheric pressure, I will subtract this pressure, this 47 millimeter of the pressure of the saturation vapor pressure in the airway. So if we subtract this 750 and this 47, it will come the exact the pressure of the gas at that time. And if we multiply this fraction of oxygen in the environment, then it will be the oxygen pressure. And if we will subtract this carbon dioxide pressure is the same in the alveoli and in the artery. So just take the carbon dioxide pressure from the ABG. So subtract this and multiply by 0.8. 0.8 is the respiratory quotient. Now, if you understand this, what is the need of this alveolar gas equation? If pressure of inspired air is low, so this is the pressure. If pressure is of inspired air is low oxygen will be delivered, like at high altitude. See, at high altitude, when we are at high altitude, maybe concentration of oxygen is just like 21% or slightly different, but pressure is low, so there will be low pressure delivered to our alveoli and there will be hypoxemia at high altitude. So this is the importance of knowing this alveolar gas equation. And other importance of knowing this, what is the difference of alveolar and arterial oxygen pressure. This is very important. We know from this formula. What is the alveolar oxygen? And we know the arterial oxygen by seeing ABG report. Just subtract this one, and if you not subtract, there are some ABG machines which already display this difference. If the difference is less than 12 to 15 millimeter of mercury on room air, or if it is less than 70 millimeter of mercury when you are giving 100% oxygen on the ventilator, then what what is the importance of this? See, if you are ventilating a patient at 60% of FiO2, suppose, or 70% of FiO2, so if the difference is more than 70 millimeter of mercury, you go on increasing FiO2, go on increasing FiO2, there will be no change, useless, there will be more oxygen injury, no benefit. So this is the importance of knowing this difference, my dear learner friends. Just know this. And if it is more, you see the same thing what I have said, if it is more, no benefit of increasing FiO2, and if it is not increasing, then the cause of hypoxemia is hypoventilation, means there is less respiratory drive either by the patient or by the machine. So now I will move on. So I will discuss the diffusion of gas according to Fick's law. The diffusion of gas is directly proportional to the area of membrane and pressure gradient of the gases. So there will be more area, more diffusion. More area means area of the alveolar membrane inside the lung, and gradient. What is pressure gradient? You already know that the gas will move from high pressure gradient to the low pressure gradient. So pressure of oxygen is more in alveoli as compared to the blood present in the lungs, and pressure of carbon dioxide is more in the capillary. So what will happen? So oxygen will move from alveoli to capillary, and carbon dioxide will move from capillary to alveoli, and it will go out. So this is the one thing. Another thing is this diffusion is indirectly proportional to the thickness of alveolo-capillary membrane, my dear friend. This is very important. If there is increased thickness, like any disease, any insult, infective, non-infective, anything, any insult will be in the interstitium of the lungs. There will be deposition of so many inflammation, debris, and tissues in that area, making it think same thing is doing the coronavirus and making the alveolar area very thick. So if it is thick, then there will be less diffusion, there will be less oxygen going inside, there will be hypoxemia. So we are seeing so many cases of coronavirus infections coming to us with in hypoxemia. So we have put two terms, oxygenation, ventilation. It will be used very frequently. So know these two terms, my dear residents, in very simple form. Oxygenation is simply movement of oxygen from environment to capillary. Ventilation is simply movement of carbon dioxide from capillary to environment through alveoli. Just know it in a simple form, and I will move on. So what is the ventilation perfusion mismatch? This is important to know. This is the very important cause of respiratory failure. So my dear learner friends, see what is here. Blood is coming. See, this blood, deoxygenated blood is coming here, and what happens here? The carbon dioxide moves from this blood to the alveoli, and oxygen comes from the alveoli to these vessels, and now the oxygenated vessels will go and supply to the body. This is the normal thing. Then what is the abnormal thing? So ventilation perfusion mismatch may be due to dead space ventilation and shunt. So what is dead space ventilation? Dead space are two types: anatomical dead space, physiological or pathological dead space. See, anatomical dead space is what? Where there is no exchange of gas. So right from upper way to the 16th generation of bronchi, there is no gas exchange. So these all are dead space. There are 23 approximately generations of bronchi. I will not go into detail. Be very simple. So see, where there is no gas exchange, there is dead space. See, here gas is coming, oxygen is coming, here blood flow is normal. Here we can see constricted blood vessels, blood flow is not normal or absent. So oxygen is coming, there is no blood. To what this oxygen will be delivered? So this is a dead space where there is oxygen but no blood. It simple term, it is dead space, responsible for VQ mismatch, responsible for respiratory failure. Now see, this is the normal. It will be very clear with this picture. So this alveoli is normal, air is coming normally, vessel is normal, oxygen is coming from the alveoli to this vessel, carbon dioxide is going from this vessel to the alveoli and then wash out. What happens here? Vessel is normal, blood flow is normal, completely normal, but the supply of oxygen is hampered due to various reasons. There may be atelectasis at that portion of the lung, no air is coming, so no air is coming here. See, no air is coming here means what? There is no exchange of blood, so this is called what? Shunting. The blood vessel is normal, no air, this is shunting. And if the airflow is normal and blood flow is hampered, this is called dead space. Now my dear residents, it should be clear in your mind what is dead space and what is shunting. These both are responsible for VQ mismatch, in turn responsible for respiratory failure. Now I will move on. So concentration of carbon dioxide in the artery is dependent upon production of carbon dioxide in the body, which can be modified by diets and metabolic rate, and it cannot be modified acutely. As you know, if you take some diet, it will not change immediately your carbon dioxide concentration in the body. It will take some time. And another factor is alveolar ventilation, that is tidal ventilation, tidal volume minus dead space into respiratory rate. This is alveolar ventilation. Why I have put this? Because dead space will not consider in alveolar ventilation, and dead space normally in a normal child is 2 milliliter per kilogram of the body weight. So this is responsible for the acute changes in carbon dioxide concentration in the blood. So my dear friends, what is our goal in mechanical ventilation? The goal is not to normalize the gas exchange. We will not normalize the gas exchange. The nature will normalize, lung mechanics will normalize. Mechanical ventilation is not a cure for any disease, mind it. This is not a cure. What is the cure? We are ventilating a patient of pneumonia. Pneumonia will be treated by different drugs. We are ventilating a patient of asthma. It is being treated by different drugs. COPD being treated by different drugs. ARDS being different by different drugs. We are not treating any disease by ventilator. It is just a support to maintain oxygenation and ventilation till a period the disease which has brought the patient to this stage get cured. That's all. This is the function of ventilator. At the same time, we intend to protect the lung from what? From oxygen toxicity, from barotrauma. Oxygen toxicity means we will not deliver more oxygen like 100% oxygen. Barotrauma will not give more pressure. Volutrauma will not give more tidal volume. Atelectotrauma will operate PEEP. I will describe everything. Will not operate PEEP in a manner that there will be repeated dilatation and atelectasis of the alveoli. It will damage the alveoli. And lastly, protect the lung from biotrauma. There are so many inflammatory mediators released in the lungs in any disease, and sometimes we are also responsible for this, because we are handling the patient in such a way that unknowingly there are so many cytokines being released in the lungs and damaging the lungs. So please be careful, and our goal is to maintain the PaCO2, that
डॉक्टर झा है डॉक्टर झा
So Jha, you are not audible now.
I think he got disconnected. I think unka network he got disconnected. So he will. I think by the time he joins, Dr. Devmalya, I think Dr. Jha, somebody please call him to join back again. So we are happy to have large number of people today, and Dr. Jha was actually telling the basic physiology and the device on which ventilation is based, and he was about to tell us about the real ventilation, how it's going to go. Dr. Jha, till the time Dr. Jha joins back, sir, who is moderating?
Hello,
Now
can
yes,
you
come.
hear me?
Sir, now you are audible, but आप पीछे पीछे जाइए, बैक कीजिए, आपकी एक दो स्लाइड
Okay, okay, okay.
हाँ,
From,
और पीछे जाइए,
yeah,
और
this point.
और पीछे, और पीछे,
Okay.
हाँ,
yeah.
अब नेक्स्ट, हाँ, ठीक है, नेक्स्ट,
Next from here.
हाँ,
So,
इसके
Jha, you were
बाद,
not
इसके बाद
audible for some time. So I think
हाँ,
you start from this slide. This slide
This
was
slide,
completed.
okay.
You can start
ये
from the next
पूरा
one.
हो गया था सर, ये पूरा हो गया था, इसके नेक्स्ट वन.
From next slide you can start.
From this slide, sir.
Yeah.
Okay. Okay, so what is the difference between spontaneous breathing and mechanical ventilation? The difference is that the spontaneous ventilation, spontaneous breathing is negative pressure, that is air is being pulled up inside the lungs because of the negative pressure inside the lung by pleural and lung mechanism, whereas in mechanical ventilation we push the air inside the lungs, so it is positive pressure ventilation. This is another graphic presentation of the same. See here, if anybody of our resident had seen the spirometer report, we will see the inhalation limb is below this line x-axis. It means negative deflection. But here, what is this? This is see this is the spirometry. This is the inspiratory limb. Inspiratory limb is, I am audible. I am audible, sir. Hello.
yes, you are audible.
You are audible, Dr. Jha. Continue.
Okay. So this is the inspiratory limb. See here, it is negative. It is going downward. It is negative. This is the expiratory limb. So this is the spirometer, and I will go to the back slide. So see this. What this is inhalation, but it is positive. It is positive. It is going up, and expression is going down. So this is the positive pressure ventilation, and spontaneous is the negative pressure ventilation. Now, my dear learner friends, it should be very clear in our mind that what types of lungs we are going to ventilate. So there are three types of lungs we are going to ventilate. One is the normal lung. Why there is need? Because the patient is unconscious. Already I have described. Another is the stiff lung, maybe due to pneumonia, pulmonary edema, ARDS, maybe due to coronavirus pneumonia, or many more causes. A stiff lung means just hardening of the lung. And third type of lung is the hyperinflated lungs, like in asthma and COPD. So these lungs are more compliant lung. More compliant lung means what? It distance very easily, more compliant. So we are ventilating these three types of lungs. Now I will describe some terms used frequently in mechanical ventilation and what are those terms. So first I will touch upon the control variables. What are these? These are variables controlled by ventilators to deliver a predetermined energy to respiratory system. The predetermined energy in the form of what? In the form of pressure or in the form of volume. So there are four main control variables: pressure control, volume control, flow control, and time control. Maximum time we are dealing with these two pressure control. So what is pressure control? In this mode of ventilation, a fixed inspiratory pressure in the form of PIP, peak inspiratory pressure. What is this? This is the maximum pressure in the airway being delivered by the ventilator, so that a certain tidal volume will be generated and delivered to the patient. So in pressure control, there is a fixed inspiratory pressure. We fixed it and it is delivered, and the tidal volume may vary in accordance with the existing respiratory mechanics. So respiratory mechanics vary according to the condition of lungs, where it is normal, where it is hyperinflated, where it is stiff lung, disease is getting cured, disease is progressing. The condition of patient is always dynamic. So this is pressure control, this is volume control. In this mode, a fixed tidal volume is delivered, whereas the airways pulmonary pressure vary according to the lung mechanics, which I have already described now. So I will move on to another slide.
डॉक्टर झा,
Yes, sir.
डॉक्टर झा, ये जो पीछे दिख रहा है ना ब्लू वाला, इसके बगल में हाइड लिखा हुआ है. कैन यू जस्ट प्रेस ऑन दी हाइड? ये ना देवांश का मैसेज आया है, तो वो देख नहीं पा रहा है. ये जो हाइड पे क्लिक कर दीजिए. नीचे जो दिख रहा है ना स्टॉप शेयरिंग, उसके बगल में हाइड है.
Stop से okay sir. Okay, thank you sir.
देवांश,
Thank you sir. Now it is clear, sir. So
Yes, sir.
yeah, now the flow, what is flow control? Flow control, a fixed peak inspiratory rate is delivered explicitly, or it is decided by tidal volume, ratio of inspiration expression, and respiratory rate. There are some ventilators we can directly put the fixed peak inspiratory rate, like in adult it is 60 to 120 liter per minute, but in children usually 12 liter per minute. So the pressure of airways in this mode changes according to the lung mechanics, which I have already described what is the lung mechanics. And lastly, there is time control mode, in which inspiratory and expiratory time is fixed by ventilator. We fix the time of inspiration expression, and the tidal volume and airway pressure both varies according to the respiratory mechanics of that particular child, and respiratory mechanics will be decided by the condition of lung, where it is normal, where it is hyperinflamed, stiff, and disease is progressing or getting cured. So I will move on, and just I will touch upon this mode, pressure regulated volume control. So this is a combination of benefits of pressure control ventilation and volume control ventilation. What happens in this mode? Tidal volume is set. We just set a tidal volume. I will say how we set. Inspiratory time is set. Ventilator means the needed inspiratory pressure. The needed inspiratory pressure will be determined by ventilator. So the pressure will not erroneously increase in this mode of ventilation to injure the lung. So this is the benefit of this pressure regulated volume control. Means we have controlled the volume, we have set the tidal volume, it is controlled, but pressure is also being regulated by the ventilator. So the inspiratory pressure in this mode depends on respiratory compliance and resistance. That is the inspiratory pressure. Peak pressure is regulated by the ventilator. So just I will describe the support modes. What is support mode? Support means what? Just we are supporting the patient. The patient is able to take breath, but not in a sufficient way. So we have to support that patient. In simple form, this is a support mode. It is clear. Support mode should be will be in the form of pressure support, volume support, or there is combination of pressure support plus SIMV. SIMV I will describe in detail. This is most frequently used terms in ventilator, and in next few slides I will describe what is this. For now, in pressure support ventilation, breath is triggered. I will describe what is trigger. Just know it. Triggered means just initiated. So breath is triggered by patient, supported by ventilator with a preset pressure like 6 to 10 centimeter of water. So it depends on the ET tube being used. If you are using ET tube of 3.5 size, then put the pressure at 10 centimeter. If you are using size ET tube 4.5, you put the pressure 8 centimeter. And if you are using ET size of 5 or more, then you put the pressure at 6 centimeter. So this should be clear. In this, inspiration is terminated by patient when the flow becomes 25% of the peak flow. I will describe in detail this portion also. What is this? But inspiration in this case will be terminated when the flow becomes 25% of the peak flow. So inspiration will be terminated and expiration will start. So in this combination mode, any breath above the set SIMV supported above the set SIMV is supported by the PSV, means there is a fixed rate in SIMV mode. If the patient is taking more breath, it will be supported by pressure support. It is a very good weaning mode. In weaning, I will describe when I will touch the weaning mode. And this is the volume support mode. Hello sir, I am audible?
Yes, please carry on.
Okay. So this is the volume support mode. It is same as the pressure support mode, but instead of a set pressure, inspiratory pressure to the support, the breath is adjusted to generate a preset tidal volume. So here pressure is adjusted to deliver a set tidal volume. This is the volume support mode of ventilation. So just to be acquainted, my dear residents, see what is this. This is the main screen of ventilator. See, this is the loop. Just if you press the button, you will see the scalars and loops different. I will show some scalars and loop. This is the monitor, and this is the trends. What trends of ventilation is going on? This is the maneuver. The maneuver we want to do, that like pre-oxygenate or the suctioning. This is the maneuver mode, and this is the extended function. There is extended quality test before starting the ventilation. You press the button, the ventilator will check everything. If there is pressure leak, oxygen is passed. If everything is passed, then only ventilator is ready for operation. So this is for just for be acquainted. This is the pressure control mode of ventilation. We control PIP, PWP rate, and this is the volume control. We just set the rate, tidal volume, and PWP, inspiratory time and flow in this. So just be acquainted with this. Now, what are the phases of ventilation? What is trigger? So trigger is nothing. Trigger is just initiation of breathing. So what triggers the breathing? Patient triggers the breathing or ventilator triggers the breathing. It is variable. So trigger patient. So patient triggers the breathing by flow or pressure set by the intensivist, or machine triggers the breathing by time set by the intensivist. So what is this? Just if you set on the ventilator pressure trigger means whenever the pressure of the respiratory airway becomes -1 centimeter, at just when the patient starts to take breath. I have already said spontaneous breathing is a negative pressure ventilation. So pressure in any child, pressure trigger is set at this -1 centimeter, and if the pressure becomes this, the child starts to take breath, and the pressure becomes this, and just the machine will sense this pressure and deliver the breath. So the another is the flow trigger. So we set the flow trigger according to the age of the child, but roughly it is 0.2 to 1 liter infants, 0.8 to 2 liter in older children. And as the flow inside the airway becomes this, the machine will sense this flow and just deliver the breath. So this is the trigger. So sensitivity of trigger should be so that the breath by the machine is delivered accurately and at accurate frequency, because if you have set the trigger too small, the machine will sense early, and there will be more breath delivered by the machine, and there will be high frequency ventilation dangerous to the patient. If the sensitivity is, you have set the sensitivity at very high, means 2 centimeter, 10 centimeter, then the machine will wait for the pressure to generate, and it will not deliver the breath. So there will be hypoventilation. So the trigger should be selected cautiously. If you are selecting pressure trigger, set at this, flow trigger, set at this. After trigger comes the target or control. So target or control both are same. It is determined by pressure or volume what we set on the ventilator, depending on pressure control ventilation or volume control ventilation. And now the cycle is set by time or flow. Cycling is what? We set a time or flow. At the set time or flow, the inspiration will end and expiration will start, and this is responsible, the target of control is responsible for maintenance of the inspiratory phase. So my dear learner friends, trigger is for start, target control is for maintenance of inspiration, cycling is for termination of inspiration, and expiratory phase variable is PEEP, which is the pressure required during expiration to keep the alveoli open to maintain the FRC, so that during expiration also there is some exchange of gases and there is no hypoxia to the patient. So now there are 4 cycles, ventilatory cycles. Change from expiratory to inspiratory, I have already said. Maintenance of inspiratory phase maintained by pressure or volume as per the volume control or pressure control ventilator. Change from inspiratory phase means the cycling. What cycling? Flow is, it is being cycled by flow or time. If we have set the flow cycle, certain flow, if the flow will be certain percentage, expression will terminate, expression will start, and expiratory phase I have already said it is nothing but PEEP. So I will describe types of breath. What are the types of breath? It depends on who is controlling the trigger, limit, and cycle. Just my dear resident, remember TLC. TLC, total leukocyte count. This is the same as trigger, limit, cycle. Just remember TLC. So what is mandatory breath? It is the breath delivered totally by the machine, mechanical breath, mandatory breath. What happens in this? The breath is triggered by machine, limited by machine means what? Inspiratory phase is maintained by the machine, and cycled by machine means what? The inspiration is terminated by machine. Everything is TLC is being done by machine. So this is mandatory breath, pure mechanical breath. So other type of breath is assisted breath. What happens in this breath? The breath is triggered by the patient, limited by the machine means, limited means inspiratory phase is regulated by the machine in the form of pressure or volume, and cycled by the machine means inspiratory phase is terminated by the machine. So this is called assisted breath. Next is the supported breath. What is the supported breath? In this, just remember TLC. So in supported breath triggered by patient means what? The breath is initiated by patient, limited by patient means inspiratory phase will be determined by patient, but cycled by machine, inspiratory cycle will be ended by the machine. So this is the supported breath. And lastly, there is a spontaneous breath in which patient trigger the breath, starts the breath, maintain the inspiratory phase, limited by the patient and cycled by the patient. So we are at this phase, a spontaneous breath. The nature is triggering the breath, the nature is limiting the breath, and the nature is triggering the inspiration, maintaining the inspiration, and terminating the expiration. All is being done by nature, and one time will come, the nature will stop our breathing and we will go from this planet. Okay, so in the graphic presentation, just I will, graphic is a separate vast chapter in ventilation. I will not go into detail, just I will touch upon some important aspect of graphics of ventilation. So how will you recognize the type of breath in the graphic? See, this is mandatory breath because it is positive pressure ventilation. So this is going outside, inspiration, expiration. This is assisted. What I have said, in assisted, patient has triggered the breath, initiated the breath. So see here, there is negative deflection. A small negative deflection means patient has started the breath, but breath has been delivered by the machine. And see here, spontaneous breath. What we are taking, just this is a negative pressure ventilation. This is the deflection, inspiration is inside, and then expiration is this. So these are the graphic presentation. Now I will discuss the modes of ventilation. So just be here for a while, it will be very clear what I am saying. Inspiration in the control mode, there are 3 types: intermittent mechanical ventilation, synchronized intermittent mechanical ventilation, assist controlled mechanical ventilation. My dear residents, just be with me for a while. I will make you very clear what is this. Do not be confused by different terms used by the manufacturers of the ventilator. In this IMV, inspiration is initiated at set frequency by machine, independent of patient effort. Patient is doing nothing. patient can take independent breath from fresh source of gas in between machine delivered breath. So if the patient is able to take, it can take it in between the machine delivered breath. And patient ventilator asynchrony may occur, especially if there is high rates set by intensivist. This is IMV, intermittent mechanical ventilation. SIMV is what? Synchronized IMV. In this mode, the machine delivered breaths are triggered by inspiratory effort of patient. So always there is inspiratory effort by patient and then machine delivered the breath. In between the machine delivered breath, a fresh source of gas is available for spontaneous breath by the patient. Patient can take fresh breath in between. When there is no effort by patient, so be clear, when there is no effort by patient, the patient receives a backup rate being set on the ventilator. So this is the we set a backup rate. If the patient is not able to take the breath, the ventilator will deliver the breath, and there is ventilator patient asynchrony in this mode. Now the assist control, this is very important mode, AC. Nowadays there is requirement of AC, temperature is hot and humid, so this is very important. AC, remember, AC means assist control. In this mode every breath is triggered by the patient, means initiated by the patient and assisted by preset inspiratory pressure or tidal volume as per the mode of ventilation. So patient triggers the breath, the inspiratory phase is controlled by the machine, and an obligatory total backup rate is set by the intensivist to receive a minimum rate of breath. It will be clear in next slide, my dear resident. See, if you have set in AC mode a backup rate of 20 per minute and the patient is able to take only 15 breaths per minute, so patient rate is 15, then what will be? Machine will deliver 5 extra breath because we have set 20 breath. So 5 plus 15 is 20. So machine will deliver 5 extra breath and all 15 breaths of the patient will also be supported by, assisted by the machine. But if the patient is breathing at the high rate set by the intensivist, we have set 20 and patient is taking 25, then what will be? All 25 breaths will be assisted by the patient. This is the beauty of AC, assist control mode of ventilation, my dear resident. This is very beautiful mode of ventilation. And see the ventilator graphs, just you recognize the graph, what the graph tells us, just recognize. See, this is the square type, it is the pressure graph. See, this is the volume graph, and any graph which is going upward and back, up and down. See the down, up, down, of it. This is the baseline, this is going down and up. This is the flow graph. So here we can see, my dear friend, this square is variable. This is different, this is different, this is different, but this volume is constant. So this is volume controlled ventilation. So it will be clear in few next slide. See this control mode, this is pressure controlled or pressure targeted ventilation, both are same. You say control or targeted. See what happens in this mode and how will you recognize. See, in pressure control mode, pressure has been fixed, that is PIP is fixed. So see the square, it is fixed everywhere. This level is fixed, but what is variable? Volume. Here volume is separate, flow is separate. So this is pressure control mode of ventilation. And see the pressure control ventilation, normal pressure control, the graph, this is the airway pressure, it is almost same. Flow is variable, volume is variable. See here what a small volume has come. It depends on the, as I've already described, depends on the respiratory mechanics of that particular lung being ventilated. So this graph is very important, my dear residents. See, in this volume control mode, what it indicates, see, this is the plateau pressure, it denotes the alveolar pressure, and above this pressure is the peak pressure. So whenever there will be airway obstruction, there will be increased resistance in the airway, there will be peaking of this, and there will be more pressure. So always we see this graph and try to keep this pressure below 30 centimeter of water. And this is another graphic presentation. See it very carefully, my dear residents, what I am trying to see, what I am trying to say. This is volume. See, this is volume. It is almost same everywhere, means it is the volume control mode. This is the flow upward and downward, and this is pressure. See, can you see the difference in the pressure? This is ascending ramp, going upward, going upward, going upward, ascending ramp. So pressure is variable in this mode. So this is the volume control mode of ventilation. Now what is the safe ventilation? So this is the volume pressure loop, and just you just will press the button of the scaler and loops on the ventilator, and you can see it. See, I will give you example. When you inflate a balloon, initially there will be more pressure required. At some point it will give up. Suddenly the balloon will inflate, and if you going on pushing the air inside the balloon, it will burst. This is the same thing. See, more pressure is required here. This is the lower inflection point. Suddenly there is more compliance of the lungs, and it is ventilated very well. And after this upper inflection point, if you go on increasing tidal volume or pressure, then there will be injury to the lung. So this is the safe portion of ventilation. You just see the scalar and loops in the ventilator and try to ventilate in this range. See, what is this? This is capnograph. Capnograph, there is a end tidal CO2 monitor. It is fit between the ET tube and the Y of the ventilator, and this graph will come over the monitor. See, this is the, as we are seeing SpO2 non-invasively by the pulse oximeter. Invasively we see in the ABG, non-invasively we see in the pulse oximeter. So in this end tidal monitor, we see non-initially the level of CO2. See, this is the 40 centimeter of 40 millimeter of mercury. So we can see what is the CO2. And if you are sitting in the ICU and there is master monitor in front of you, you can see all the patients at a time. Then in this graph, changing graph, when the graph will change like this, it means that patient is hyperventilating. If the graph is changed like this, that patient is hyperventilating. Just move on and go to the patient. There is something wrong. My dear learner friends, now this is the very important thing in ventilation. Try to understand it in a very, very simple way. What is time constant? It is product of compliance and resistance. It is time taken for alveolar pressure to become equal with the airway pressure, and it is time taken to ventilate 1 unit of lung. So what is the importance of this time constant? Why we want to know the time constant? To set the inspiratory time on ventilator. So if you are just as you have opened the panel and you have seen the compliance and resistance of that particular lung being ventilated, just multiply it and see the time constant, and just set the time constant according to this. It takes 5 time constants for equalization of pressure to 99%. So if the time constant is like 0.1, just multiply it with 5 and it will be come 0.5 and set the inspiratory rate at 0.5. See, normally if you don't want to do this calculation, just remember in infants Ti is 0.4 to 0.7, in children 0.7 to 0.9 seconds, adolescent 0.9 to 1.2 seconds. Set this and set the respiratory rate in infants and small children 40 to 20. See, I have put it in a reverse manner. Usually in books it is written 20 to 40 and 15 to 25. Why I have written in reverse order? Because as the age increases, respiratory rate decreases. So if the age of your child is increasing, so decrease the respiratory rate according to the age of the child. You set the respiratory rate on ventilator. Now my dear friends, we are in ICU. What we'll do, see, just to be acquainted, my dear residents, see what is this. This is ventilator. This is ventilator on the standby mode. What does it mean and what this person is doing? So usually power button is on the back of the ventilator. There are two connections, one is the medical air, one is the oxygen. And if there is inbuilt compressor in the ventilator, there is no need of that. There is expiratory inspiratory limb of this tubing. There is expiratory chamber, and there is humidifier. All you have to set it. And if you are working in ICU, if there is call from the ward, you just do all these workings and make the power on and keep the ventilator on standby mode. So as soon as the patient enters your ICU, just start ventilation without delay. So what should be the initial ventilator setting? So, my dear friends, initial ventilator setting depends on which mode you are using. In volume control, tidal volume in smaller children should be set at 5 to 8 ml per kg. This is ml, not mi. It is a mistake. And in older children, this is 8 to 10 ml per kg. There is an universal acceptance that if you don't remember age wise, just remember in every child, in any group of child, 5 to 7 ml per kg is the set tidal volume. And in PCV, pressure control ventilation, we set PIP between 18 to 25 centimeter of water. But if you are a good intensivist and we have a good facility, you just ventilate the child with ambu bag. There is a pressure monitor connected to the ambu bag, and see the chest rise. If there is adequate chest rise, then see at that time what is the pressure displayed on that monitor, and that will be the exact PIP for that baby. If not, then just put it in between. And rate should be the physiological rate according to the age of the child. So what is now
Dr. Jha,
this is the physiological PEP is
डॉक्टर झा
yes sir.
जैसे सेकंड हाँ मैं इनफैक्ट बोल रहा हूँ ये जो भी लोग हैं सारे रेजिडेंट डॉक्टर्स एवरीवेयर बिकॉज दिस इज द प्रिस्क्रिप्शन ही इज गिविंग एंड आई थिंक even if you note down the settings, initial settings, we would be able to handle this. तो आपने बाकी फिजियोलॉजी समझे ना समझे, आप वेंटिलेटर पे अगर ये सेटिंग्स और नॉब्स आप समझ रहे हैं तो आप उसके बाद कोई भी व्यक्ति भले वो पीडियाट्रिक से हो, मेडिसिन से हो, ईएनटी से हो, सर्जरी से हो, ऑर्थोपेडिक से भी हो, उसको अगर इनिशियल सेटिंग्स के बारे में पता है वो सर आप
Sir, just let me finish everything, and you are most welcome to modify, add or delete anything. Just let me finish first, I request you. So PEEP is the physiological PEEP is just 2 to 4 centimeter of water. IU ratio normally is 1:2. In volume mode, the time variables depend on tidal volume, frequency, flow, resistance and compliance of the respiratory system. FiO2. So initially it should be kept at 100% in respiratory failure, except in preterm babies and some cardiac cases. In these cases it should be kept low, and gradually it should be brought to less than 60% according to the condition of that child. So my dear friends, I will give you some setting, but I am giving just a roadmap. Like if you are going to play cricket, and if there is a fixed score in your mind that I will my team will make 350 runs to win, it will not work, because it will depend upon the pitch condition, quality of bowler, quality of fielder, distance of boundary. So go with the fixed mind, but be flexible, because the condition of patient is always dynamic. Even if your team scores 350 runs, you can lose the game. Even if your team scores 220 runs, you can win the game. Even if you have made century, you can lose the game, because the winning will depend on effort of your all team members. So just it is initial setting for the roadmap. So this is for pneumonia, and this setting for asthma. In asthma, what we do, tidal volume should be kept a bit high. PIP should be kept a bit high. PEEP should be kept low, because there will be less venous return to the heart. There will be less delivery of the blood from the heart to the periphery, and the patient will go into shock. So PEP should be less in cases of asthma, bronchiolitis, and rate should also be less, and I ratio should be more, because we should give more time for expression for the carbon dioxide to get washed away. So what should be the setting of pediatric acute respiratory distress syndrome? Let me explain these things. If your pocket is small, and I am giving something into the pocket, and giving, your pocket will turn away. So if I want you to maintain your financial condition, I will give, if your pocket is small, I will give money in small aliquots throughout the month. So is the case of this in betting ventilator in PRDS. Keep the tidal volume small, because if you will give more volume, lung is stiff, it will cause injury to the alveoli. and pressure should be of the between the 5 to 12 centimeter of water, and rate should be a bit more, because low tidal volume, more frequency will ventilate the lung adequately, and I ratio should be either 1:2 or low, and if it is 1:1, it is called inverse ratio ventilation. So if you are ventilating a normal lung like in an unconscious patient, tidal volume should be at the rate of 6 to 8 ml per kg. PEP should be 3 to 4. Rate is the physiological. I ratio 1:2 or 1:3. So what do you want to achieve by these mechanical ventilation? We want to achieve SpO2 between 82 to 92% in preterm and severely diseased lungs, except in anemia and pulmonary hypertension. In terms neonates, we want 90 to 95%. In children after the period of newborn, we want 92% to 97%. And in children with some congenital cardiac disease, we are satisfied with the SpO2 of 70 to 75%. And at the same time, we want to keep PCO2 below 45%. And at all cost, we try to keep peak pressure below 30 centimeter of water, and this should be achieved at FiO2 below 60%. So what are the determinants of oxygenation and ventilation? So determinants of oxygen are FiO2, MAP. I will describe what is MAP, PIP, PEP. We already know. I ratio already know. Flow of gas already know. What are the determinants of ventilation? So minute ventilation is a product of tidal volume, respiratory rate. Alveolar minute ventilation, tidal volume minus data space into respiratory rate. Data space is 2 ml per kg. As I have already described, and the total volume depends on compliance and resistance of the lungs. And what is delta P? Delta P is the difference of PIP and PEP, and each is responsible for generating the tidal volume. And we set the rate, regulate the rate for the ventilation, and we regulate TITE for the ventilation. And in simple term, I have described at the outset what is oxygenation, what is ventilation. And for remembrance, tracheostomy should be done if ventilation is required for more than a week. Then another term is what is permissive hypercapnia and permissive hypoxemia. Just I will touch upon. We accept the PCO2 level of 50 millimeter of mercury to protect the lung as long as the pH is less than 7.25, and we accept this level of 55 millimeter of oxygen if there is no anemia and no pulmonary artery hypertension in the patient. These are to protect the lungs from various injuries. So these are the protective strategies, not to traumatize the lungs. I will not go into detail. Just I will touch upon the ARDS and PRDS. Just pediatric ARDS. So there are various definitions of ARDS. It should be acute less than 7 days. There should be diffuse involvement of lung. Cardiac causes should be ruled out. Pulmonary edema. All these things. But in ventilator terms, according to the Berlin consensus, adult ARDS has been classified according to this ratio of PaO2 of FiO2. Mild is between this, moderate is between this, and severe is between this. And pediatric ARDS has been classified better according to the oxygenation index. And what is this oxygenation index? It is this product MAP into FiO2 into 100 divided by PaO2. And saturation index is what? This saturation index. If you replace this PaO2 by SpO2, it comes as saturation index. So what is the normal MAP, mean airway pressure? In children it is 5 to 26 centimeter of water. And how we calculate MAP? We can calculate MAP, just multiply PIP into Ti plus PEP into T divided by Ti plus T into the constant. So on the basis of oxygenation index, better classification of PARDS is done on the basis of oxygenation index rather than the ratio of PaO2 and FF2. And on the basis of this, mild PARDS is 4 to 8, moderate is 8 to 16, and severe is more than 16. And if you are using saturation index, mild is between 5 to 7, 7.5, moderate is 7.5 to 12.3, and more than 12.3 is severe. Now some troubleshooting while we ventilating the patient. Just remember dope test is very popular in athlete and the sports world. So D is for displacement. We are sitting in the ICU, see all the patients on the master monitor. If there is sudden fall of the saturation, think first D, is there displacement of tube? If it is not, think if there is obstruction of the tube. If it is not, see if there is development of pneumothorax. If it is not, see if there is equipment failure. Just disconnect the child and ventilate manually and see what happens. And this is very important to know. If the displayed expiratory tidal volume on ventilator is less than the inspiratory tidal volume, there is leak in the system, and you check the leak and correct it. So these are the medicines being used for the synchronized ventilation, so to minimize the ventilator patient asynchrony. And the most common cause of asynchrony in children is agitation due to hypoxemia. If you correct hypoxemia, if you ventilate the child properly, if it is not hypoxemic, there will be less agitation and there will be less need of this medication. This is theoretical, but practically we need these medications. I will not describe the dosage of this medication due to less time. Now start weaning. When you start weaning, if the child is hemodynamically stable, there is no vasopressor being used, it is off vasopressor. No, if you have given the feed on ventilator, you can give the child feed on ventilator. So if you have given the feed, the child should be off the feed in the last 6 to 8 hours. FiO2 being used is less than 40%. There is no chest retraction. Adequate ventilation drive by the patient. Adequate gas exchange with minimal settings on the ventilator. And there should be significant improvement in disease affecting the lungs. And ventilator support should be minimal, that is tidal volume 4 ml per kg, PIP at 15, respiratory rate is this, pressure support is this, and direct weaning can be done if you have ventilated the child for less than 72 to 96 hours. Just give the spontaneous breathing trial several times a day. Just make the ventilator off, watch the patient for few minutes, and then the ventilator. This is spontaneous trial. If it is tolerating, then disconnect and off the child. But if you have ventilated the child for more than a week, do not directly wean off the child. Put on the pressure support mode or CPAP, then only wean off. If you can use or not use dexamethasone depending on your expertise. If you have traumatized the airway, then you can use this at the rate of 5 mg per kg hourly 3 doses before extubation. And if you have extubated the child and you have observed that there is noisy breathing, just nebulize with adrenaline. Problem will be solved. And few points regarding maintenance: ventilator tube should be changed every 72 hours. Water in humidifying chambers should be changed daily. Saturation of inspired air should be 80% with water vapor. Temperature should be maintained close to 37 degrees Celsius, and there is thermal detector at the end of expiratory tube. And if you want to know more about the mechanical ventilation, just go through the Rogers textbook of Pediatric Intensive Care, European Respiratory Society guideline on mechanical ventilation, of which I am a life member, and American Thoracic Society guidelines on mechanical ventilation. And how can I forget my teacher, my guru, my mentor, Dr. S.K. Kabra? Just go through the book written by Dr. S.K. Kabra and Dr. Rakesh Lodha, Essential Pediatric Pulmonology, and I am PICU protocol, and you can refer Nelson Pediatrics. And I have learned so many things from the expert of Boston Children's Hospital, USA, regarding mechanical ventilation. Thanks to them. And this is my last slide. The take home message is, see, my presentation is based on principle of KISS. So this is the kissing swans. What you are doing being reflected here, my dear friends. Whatever you are doing being reflected here. No one is seeing you inside the PICU. You and patient is there. Patient is also unconscious. So do your work honestly, and it will be reflected anywhere in the world, in the nature. So do your work honestly. Say honestly, do honestly. Once you enter the PICU, be actively calm and calmly active. So try to understand what I am trying to say. The man who has saved one life has saved the world. In cricket analogy, try to get maximum score and at the same time protect your wicket. Means you are working in the ICU, you protect yourself also from the different infections. Future is uncertain, but wherever I will be in this physical body, my support will be there to all my lovely residents through either my physical or virtual presence. Thanks to all. I finish my topic here. If anybody need any clarification, I am here to clarify according to my little knowledge and little experience. And if there is no questions, I would like to finish my talk with a beautiful poem in Hindi, if Dr. Saini and the organizing member will allow me. Thank you very much.
अरे अभी तो क्वेश्चन नहीं है.
Thank you, Dr. Jha, for such a lovely talk. We learned a lot from your talk. You made this difficult topic so simple and worth listening. And your guidance and experience is very important for residents and even senior people also. Now I will open this house for question answer session. Before listening to your poem, we will have some questions.
Yeah.
अच्छा, डॉक्टर झा एक मिनट, देवांश ने क्वेश्चन लिखा है. That is, what is E? ब्रैकेट में आप चार पे पढ़ लीजिए. E sense percentage में, what is that?
I am not able to hear clearly. What are you saying? What is?
Can you just look at the chat? Chat पे देवांश ने क्वेश्चन पूछा है. What is E sense?
What is? I am not able to see the chat. Sir,
I can see the chat. नीचे तीन डॉट होते हैं, तीन डॉट. स्टैंड में क्लिक कीजिए.
can you forward me the question on my WhatsApp? Can you forward me the question on my WhatsApp, please?
Devansh can otherwise talk and say. Devansh,
Yeah, Devansh, please ask. Devansh, please ask me the question. Hello. Am I audible?
Yeah, Dr. Jha, Dr. Devansh is asking you the question.
Yeah, Devansh, ask me the question, please.
Dr. Jha?
Yeah, yes, sir.
Dr. Devansh is asking what is the meaning and function of E bracket sense given in percentage.
E
bracket he has written sense, S-E-N-S, and given in percentage.
E rapid sense.
E sense.
I'm not able to get the question. Can you please forward me on the WhatsApp? I will answer it.
Devansh, can you just speak out loudly? Devansh, you speak out loudly and ask Dr. Jha.
Audible, sir?
Yeah, Devansh, please ask.
So in this ventilatory parameter, when we start ventilating a patient, there comes parameter E sense. And the units which it is being given and we can adjust is in the terms of percentage. I just wanted to understand what is the meaning of.
Yeah. So there are different settings in the different ventilators. E sense. What is the E sense? The electronic sense, you are sensing the machine ventilator is sensing the effort of the patients, and the ventilator is delivering the required percentage in the form of tidal volume or the pressures to the patient, to the airway of the patients. So sensing is this. So what the ventilator is sensing and what the ventilator has to do, and it is being seen in servo control mode of ventilations, mainly. Not in all ventilator you will see this mode. In servo control ventilations, there are so many things automatically being regulated by the ventilator by e-sensing. If I am right, then okay, and if I am wrong, you can please correct me.
Devansh,
can you hear me?
Are you there? I think that question has been answered. Any other question from any other person, please?
I think Mohit is asking something. Mohit, you can ask.
Good afternoon, sir.
Yeah.
So what is heart-lung interaction during mechanical ventilation?
Yeah, heart-lung interaction
Wow.
with ventilation.
Wow,
Yeah,
that's great.
I have already touched upon something, heart-lung interaction, like in asthma. If you are ventilating the lung with a bit high PEEP, there will be less venous return to the heart. In other terms, there will be less delivery of the blood from the heart, and the patient will go into the stage of shock. So this is one point, and there are so many mechanics which is affecting the heart, ventilator, and lung. So the most important for us to know is the regulation of PEEP, which is affecting the mechanics of heart. So it should be regulated properly in the normal lung, in the stiff lung, and in the hyperinflated lung.
Mohit,
That's all.
Mohit, heart-lung interaction, especially in terms of high-frequency oscillation, is important because there we are keeping the lung stretched with a gap of around 12, 13, 14 centimeter. तब तो पीप हम बढ़ा के 12, 13, 14 कर रहे हैं, पूरा लंग ओवर इन्फ्लेट कर रहे हैं और हार्ट को हम वीनस रिटर्न कम करना चाह रहे हैं. But even with this, with the beating of that heart also, जो हार्ट का बीट है, that actually improves the diffusion in the stretched out alveoli. So both ways, increased beat can decrease the venous return, whereas beating of the heart can improve the diffusion as well. So heart has some interactions during ventilation, and ventilation can impair the venous return and to the heart also. So there are two-way interactions.
Any more question or any more clarification?
If there are no more questions, Dr. Jha, you were talking about some poem. We would like to hear it from you.
Hello.
Yes,
Hello.
yes, sir. Yes,
Somebody
sir.
Please.
Yes, sir. Because I am closely associated with so many poems and music. I will recite one poem from written by Ramdhari Singh Dinkar, and the birthplace of Ramdhari Singh Dinkar is the same birthplace as my birthplace, that is Begusrai in Bihar, and he has written Rasmi Rathi. This is very popular. He is a national poet. So just it is a vast poem, but just few line I will recite
here.
Sure,
Definitely we would like to hear.
बरसों तक वन में घूम घूम विघ्न और बाधा को चूम चूम पांडव आए कुछ और निखर सौभाग्य न सब दिन सोता है देखें आगे क्या होता है मैत्री की राह बताने को सबको सुमार्ग पे लाने को भयंकर विध्वंस बचाने को दुर्योधन को समझाने को भगवान हस्तिनापुर आए पांडव का संदेशा लाए क्या दो न्याय अगर तो आधा दो न्याय अगर तो आधा दो अगर इसमें भी बाधा हो तो दे दो हमें सिर्फ 5 ग्राम रखो अपनी धरती तमाम हम वहीं खुशी से खाएंगे परिजन पर हंसी न उठाएंगे दुर्योधन वो भी दे न सका आशीष समाज का ले न सका उल्टे प्रभु को बांधने चला जो था असाध्य साधने चला प्रभु ने हुंकार किया रूप अपना विस्तार किया डगमग डगमग दिग्गज बोले हरि कुपित होकर बोले जंजीर बराकर साध मुझे हाँ हाँ दुर्योधन बांध मुझे. That's all.
Yeah, very well recited.
Very good, very good.
Very nice. Now I think after a hectic session, I would like to thank all the participants for listening patiently, and especially Devansh. Devansh, you are here.
No, sir, Pranshul ने question पूछा है. Sir, there is a question from Pranshul.
There's a question. Okay. Then
what should be tapered first, and in what order during weaning?
Yes, I will have to reply this. See, how we should taper the ventilator setting. So if you are ventilating the child on pressure control mode, so the pressure, the PIP should be decreased at a time of 1 to 2, not more than that, number one. And rate should be decreased to 2 to 4, not more than that. And FiO2 should be decreased in the percentage of 5%, not more than that. 1% increase in FiO2 or decrease in FiO2 makes the difference of 5 millimeter of mercury of oxygen in the arterial oxygen. So what should be decreased first? Rate should be decreased first, pressure should be decreased first, and volume should be decreased first. What should be decreased first is dependent on what mode you are using, number one, and what is the disease condition of the patients, and what progress has been by the treatment of the disease condition of the lung. So if it is permissible, any setting you can decrease or increase, but my dear residents, Mind it, if you are decreasing or increasing the setting of ventilator, just for confirmation, just 30 minutes after that, do the ABG and see what changes you have done. That's all from my side.
Partially from this.
Yeah. Any more questions?
Hello.
Yeah.
Dr. Ganesh. Dr. Ganesh.
Yeah, Dr. Gyanesh. Yes, sir.
हाँ सर,
Sir.
बताइए बोले.
I am hearing, sir. Please ask question.
So I am audible.
Yeah.
Just no question. Just I am thanking Dr. Jha. I am from Patna Medical College. Dr. was associated with it during PG studentship. I was a senior resident there. I am very glad to hear from such a deliberation from our student. So my heartiest thanks to Dr. Jha, why he has risen to so much speed. And from an institution where there was no setup of any ICU and no setup of any ventilation, has gone to such extent. My heartiest thanks and my heartiest regards and blessings to Dr. Jha.
Thank you, sir. Thank you very much, sir. Pranam, sir.
Thank
Dr.
you.
Hemant.
Very glad for you. Thanks a lot. I would like to your presentation on my WhatsApp.
Thank you, sir. I will send, sir.
Thank you. Lots of love. Thanks.
Pranam, sir.
Thank you.
Yeah, thank you, Dr. Hemant, for your kind words. I think now, if any more questions, if there are no more questions, I would like to thank all the participants for participating in this seminar series of continuing medical education, which was well organized by Dr. Ekta, and I thanks Dr. Ekta for also for organizing this series very efficiently. And I thank my department and my residents also for cooperating, and they are for their willingness to share knowledge and good things in the life. Thank you very much. Thank you all.
Thank you, sir.